everybody. Any apologies to note? I think obviously we've got substitutes in. We can pick those up. But any other apologies? And is anyone on call today? No on call directors, fantastic. Any declarations of interest relating to the agenda? No, this could be very, very quick. And we don't seem to have any minutes to approve. I'm trying to think why. I've only just noticed that they're not on there. There must be a reason, so we don't have any minutes to approve.
Hang on a minute. It was because there were no previous minutes to approve because the public minutes were approved at the private committee last month. Fabulous,
thank you. Bev, did you want to come in? Or were you going to make the same point? Fabulous. So that moves straight on to my update. My update is very simple in this meeting, which is basically we have a fairly light agenda in the public section, but obviously very important, both forward view, the digital report as well. I think with light of all the GDPR sensitivities and also all the progress made, that deserves particular attention. And then the ratification of the decision around local funding, which obviously many people have been involved in discussions about, but we do need to formally go through that for approval. So we move straight on to the forward view. Is Kieran with us, or is someone covering for Kieran?
It'll be me, Andrew.
Julie, I did get your note last night. I just didn't have time to respond, so thank you. So over to you, Julie.
Thank you very much, Andrew. Thank you. So just an update really on where we are with the PCNs, so the primary care networks and also the network contract. Des, we know, and we updated the committee before about the fact that we have got our 16 PCNs still roll forward from the 1st of April, which is extremely good news. All the practices have signed up and are still part of the same PCN. So as a county, we still have 100% coverage, which again is very, very good news. And I just wanted really to give an update of what that means around the for the PCNs for this particular year. There are 3 new specifications that are coming online that will start from the 1st of October. So even with COVID, there still is an expectation that these specifications are introduced from the 1st of October. So the first one being enhanced health in care homes, and we are working very closely with the clinical directors in the PCNs and the practices around aligning care homes to each of the PCNs. That needs to be done by the 31st of July, and also a clinical lead identified. So we're working very closely, as I say, and very hard to make sure that we hit that deadline of the 31st of July. Then the actual activities within the contract, which includes things like the weekly check-in, making sure that people have got advanced care plans, and that they have medication reviews, etc., actually starts from the 1st of October. And again, we will be working with people very closely to be helping them and making sure that they have support to be able to work with those multidisciplinary teams. The second is early diagnosis of cancer. So this is, again, extremely important. Especially given what we know and understand around the whole cancer agenda, which is a national agenda just at the moment, to be making sure that people are identified early. And then the third specification is the medicines optimisation and structured medication reviews. And that is for people who are on multiple medicines and that they have a pharmacist and a pharmacy review on a regular basis. That includes whether you live and reside in a care home or whether you are somebody that lives at home. So those are the 3 main contract changes and specifications that are being introduced from the 1st of October. And I wanted to update the committee. I will stop there and see if there are any questions.
Okay, so we open it up to questions. I see no hands going up. So I think we therefore formally note the paper. So thank you very much. We move on to Kirsty and the digital report. So would you like to give us a sort of précis of the main points there, please, Kirsty?
Yes, so the key thing is during COVID, we took the opportunity to ramp up rather than ramp down on the IT initiatives, and actually have moved ahead of our strategy for IT this year. In particular, we've moved exceedingly fast on the online triage and video consultation, and we've deployed video consultation across every GP practice in the county, and all of them have taken that up actually very well. We've had some quite good feedback around some of the tools that we've deployed, and that has helped to continue to deliver services to patients even when we've got the ongoing situation with COVID, because every patient was triaged to identify whether they needed to be seen face to face or whether they could be dealt with via video consultation, and then they were routed appropriately. We've also deployed out laptops to every GP, and we're continuing to deploy out further laptops to add future resilience for other clinical community-based staff. We've deployed quite a lot of webcams and headsets as well to make the video consultation a little easier, and those have been well received. And nationally, they've deployed summary care record extensions that allow some additional patient information to be shared to support the COVID initiative. There's also been a wider deployment of GP Connect, which obviously uses the GP information, but it allows 111 and out-of-hours services to book appointments directly into GP practices, which has helped to improve the efficiency of those services where we've used more 111 care. We've also done a lot of initiatives to help with the acutes and the community, and into some of the care homes, but the GP initiatives was what I particularly wanted to bring to your attention. But the video consultation for care homes is particularly relevant because it's allowing them to continue to provide care, even if there are limitations with getting to a care home. They can provide video consultation to those patients and triage them to identify those that need emergency care. And then a quick look at what we're doing on our more strategic initiatives. So we're in the middle of deploying the Northamptonshire Care Record, and this is an initiative aiming to bring together data from all GPs, from the 2 acutes, from the health in the community, both for mental health and for children, and also looking at bringing in information from the county council, and that's looking at, again, adults and children, and how we bring that data together for the purposes of direct care. So anybody that has a patient sat in front of them that they need to care for can see a holistic record across all of those institutions to ensure that we're making informed decisions. And a lot of that information is currently not available. People tend to assume, but it's not available in those areas. So that should help us to ensure that there's nothing missed when reviewing a patient. The other things that we're working on, we're doing a really rapid deployment of a pilot for the personal health record. And that's particularly going to help us with some of the advanced care planning and working closer with our care homes, because our personal health record will allow us collaboration between the patient, the clinician, carers, care home workers, and other people that the patient chooses to allow access to their record. It's a consent-based model, so the patient is the holder of the record and they can choose who they share it with. But it does mean that a lot of those paper forms that currently are provided to care homes will be completed with the carers online with the patient and shared back to those GPs, reducing some of the admin, but also making it real time and making the patient at the heart of that. It's a really rapid pilot, and we've actually got the procurement completing at the beginning of August. So we're quite pleased to have turned that around quite quickly. And hopefully that should mean that it will really help that initiative in October. And then the last areas that we're working on, it's around population health. We've called it the NARP, it's the Analytical Reporting Platform. And that's bringing those same types of data sets together, but utilising those for statistical reporting analysis, which will help us with some of our restoration planning and some of our more complex planning for the future, bringing those data sets together and segmenting those data sets so that we can focus on which ones are safe to look at that don't contain personal information, and we can use those for our statistical planning without risking sharing patient information with people that aren't appropriate to view it. And we can also then have those complex sets that involve very personal information that the GPs and the clinicians can use to use that deep analytical views on that data to use for direct patient care. So it's quite exciting at the moment. We're pushing forward quite hard for you.
Fabulous, thank you very much. A massive amount of work. I think first of all, it'd be interesting just to get a GP view of how it's all going, because it's also been at massive pace. So, Sanjay, if you're happy to give us sort of a response in terms of how it feels from a general practice position.
In summary, a very steep learning curve. It's actually all fallen into place slowly, and certainly from my perspective, working on the coalface, it was a bit of a juggling act at the beginning, especially when you don't have the equipment, you're dealing with new IT, you're dealing with new things. But certainly now we've come a long way. You know, all the things that Kirsty listed, it comes into a neat list, but it's been a big feat of work from her part. And also, you can imagine trying to get a laptop to every single GP just physically is not an easy ask, as well as all the security that goes behind it. So it's helping. It's creating a new way of working. Now, how the dust settles on that and how the future looks on what normal primary care will look like, I don't know. I think every week I read something from various national organisations and they have a different slant on it. And I'm sure Jonathan here is the same as well. It does appear to be that this is going to be the new normal. I think primary care as a service delivery are actually managing it extremely well, and they're putting in new processes. They're also, you know, we're working from home. Who thought GPs will be working from home on this scale? But it provides an element of resilience and security that if a practice does suddenly start to go down, then we are not confined to the building. And also, I mean, I'm sure private sector companies have done this in the past where they don't have all their staff in one place for business resilience. Well, you know, we're having to look at that as well. Do we have staff deployed in different places so that we don't all come down with something? I think the hardest battle is almost getting the message across to the public. That's the hardest part. And the example I give, and I'm sure many on this call have heard it, is 15th of June, the shops opened, and suddenly the mood in patients changed in that they thought the front door of general practice suddenly opened up, service as normal. And we're still going, you know, giving the same message across that we get that we've got to get back to normal, but it's a new kind of normal, and you can't just walk in. There's too many risks from just walking in, and so we do need to keep triaging. But I think it's a changing ballgame. I think as we go forward, there's going to be a definition of what primary care is normally, which isn't going to look like the past. From my perspective, I can't see it going back to, you know, your clinics in the morning, clinics in the afternoon, waiting rooms full of patients, screaming children, usual. There is going to be a new normal. I'm not sure what it is, but I think we're adapting. Practices are working together, which is really nice to see. And I think, you know, there has been the good levels of communication between primary care practices, but also the CCG and primary care. And now we're starting to get the place. There's teething problems. There are still issues, but we're working through them. So hopefully that's a flavour.
I notice Julie's got a hand up. So Julie, over to you.
I just thank you, Andrew. I just wanted to thank both Kirsty and her team and also the GPs. We couldn't have done this without everybody pulling together, and Kirsty's team and also the GP practices. For the record, I think I would personally like to thank everybody for all the hard work that they have done in such a short period of time. Given that this was a rollout over 2 years and the practices did it in 6 weeks, I think it's testament to the amount of work and the amount of drive and determination to be able to get this up and running. And on a second point, I would also just like to say the Northamptonshire Care Record for me is an absolute game changer. We've been trying to get this information around people, this holistic information about people for a long time, and for the first time I feel quite confident that actually we'll be able to have that this year, and that will be amazing. So I just wanted to pop those two comments in the room.
I think obviously we should, the committee's thanks should be passed on to the team and noted in the minutes. So thank you very much. It is an exceptional effort. One of the things that when things happen at pace, as Sanjay says, there's a massive learning curve, both from a user point of view in terms of general practice, but also the recipient, the patient at the end of it. So there's one thing there around making sure that you've got the support in terms of patient communication. And the second question from me is around the fact that we have more laptops out in personal spaces and personal domain obviously presents a significantly increased GDPR and security issue. What steps are there being put in place to ensure that we have a sort of heightened sense of security awareness to protect patient data?
That's a good question, well asked. So obviously the GPs are already very, very mindful of their data and how to protect it. There's no access from the individual devices without them being connected through to the clinical systems, and that requires the GPs to use their smart cards. So they've got that two-part authentication, so that gives us an additional level of protection, and I guess they guard that with their life to some degree. And I'm hoping Sanjay's going to back me up there as he comes in on that one.
He has his hand up, so we'll hand over to Sanjay to say.
Yeah,
please.
No, I agree. I mean, the security is probably more strict on the laptop than it is on the desktop PCs that you work with in a practice. You almost have to go through 2 layers of security to access patient record using a laptop. You need one to actually open up the laptop, and that personally attaches you to it, and the second one is your smart card, which you'd use on any device. It's certainly in our practice when I work with Amar, so I'm a testament to this. We've got everyone to sign their life away, and we've almost everyone does GDPR training, everyone does IG, and now we've got them to sign further forms when they're taking the laptops away, just to say that this is still the same as though you are working on site. This is not to be used for other things. So we've created it ourselves, but I think just to emphasize that element, that this isn't something you go home and you start doing other things on and you let the kids play on, because it is a work computer and it has to be treated as such. We also, certainly in our place, have put things out to people, in terms of making sure your room's right. And there's an element, some people can work from home. I don't know how to explain. Some people can work from home, some people can't. So certainly in our practice, I know other practices doing this, it's given us an option that have the laptop as a backup if you want, and some people may not open it very regularly. But if you do choose to work from home, if it's possible, then it's an option. And we've had quite a few who've said, you know what, there is no way because I've got so much noise, so much background, I haven't got the private space to do it in. So many are using it, and many is sitting there, and when they have had to self-isolate, then it comes out. So I think, it's various methods it's used, and also it's allowed us to use other space which probably wasn't counted as clinical space in a practice more easily, because the laptop just fires up and we can use, an office that potentially wasn't a clinical room before. So yeah, there's lots of things we've put into place, and I think we're all very careful in terms of IG. It's one of the things we're constantly checked on and do training on. So yeah.
Excellent. Are there any further questions? So I guess the message is one of a support. Thanks for all the hard work that's gone on, and a message of continuous improvement. I think having made this sort of step of 2 years work in 6 months, it's making sure that we don't treat it in stages, that actually we start thinking about how can we continuously improve on this and keep on adding and support. You want to come back in, Kirsty, so I'll let you come back in.
I was just going to respond to that actually. During the process, the primary care cell did identify that there was a gap in our strategy because we'd leapt forward with our IT developments now, and we haven't got things that we were aspiring to beyond some of our more regional ones. So we're working together on a new digital strategy for primary care, which will ensure that we use this as a platform and keep moving forward.
Well, we look forward to receiving that, and I know Bev will be very keen from a patient engagement perspective to think about how we can support that in terms of getting the message across both to the internal side and the external patients as well. So brilliant, thank you. Okay, moving on to Julie and the reimbursement funding local discretion paper, please.
Thank you. Thank you, Andrew. So we've got we know from the new contract, the new network contract DES, that there is something called additional roles funding, which is called R's funding. This funding is for a set of people that are predefined roles, and it's going to be incredibly difficult this year due to COVID, right, for the PCNs to be able to recruit to all of the roles that they may wish to, and to actually therefore be able to use all of the funding that is available. And it's considerable funding. It's about £5 million, so it is considerable funding, and that means that there will be there could be an underspend on that. So the clinical directors approached us and asked whether or not they could increase the cap. So there's not a cap on many of the roles in the R scheme, but there is a cap on physiotherapists and pharmacists, and they approached us and asked whether or not they could have 2 whole-time equivalents instead of 1 whole-time equivalent, which is what the kind of the rules are. Now, we as a CCG, we have the ability to apply discretion to this cap, and we obviously double checked with NHS CCG, sure that this would be something that would be allowable. Excuse me. So it was very driven by the clinical director's request about wanting them to be able to have 2 rather than 1. I reviewed the situation and the request at the time, which was at the end of June when they'd asked me, so that we can kind of try and get on with the recruitment. We have, as you may remember, last year we had big county-wide recruitment drives where we were very successful about being able to bring in pharmacies and physios, and also the link workers, the social prescribing link workers. So there is no financial implication to the CCG because it will all remain in the financial cap. This is about buying more people within the current funding allowance. So I did say, because they wanted to get on with it quite quickly, I did approve their request, and I bring the request to the committee to ask for ratification of that decision, please.
So I'm going to open it up for questions. I don't see anyone sticking their hand up. Jonathan.
Obviously, the more flexibility, the better, as far as I'm concerned, for practices and PCNs to be able to employ these staff. One of the issues would be when the whole point of the cap was around availability of staff, and the worry that you would take staff from one area to another and actually just rearrange the deck chairs rather than achieving very much, and maybe destabilise one organisation against another. I'm not sure that those additional physios or clinical pharmacists are actually available. The clinical pharmacists probably more so, but be that as it may, the other point is any unspent ARRS will be lost if we're not careful. And we have asked this question before. Julie's aware of this. What's happening to the underspends, because they are meant to be as I understand it, they're meant to be reinvested within general practice somehow, because in the following year, they will not reappear. You only get each year's allocation as it comes along, and Julie will correct me if I'm wrong on this, but I think that's the case. And so there is a possibility that you'll get one PCN that hasn't managed to recruit or wasn't active enough in recruiting as against another who will never be able to catch up. That PCN will always have less staff because they didn't employ them in that particular year. And it would be important to make sure that the funding that wasn't used was somehow used to be able to support them or other PCNs in some way. And I'm sure Julie agrees with that, but how we do that is going to be the question. How do you identify that spend?
Yeah, so I'll try and take both of those questions. So the bit about the labour market, we will be making sure, so at the moment we can't see an adverse effect on the labour market just at the moment for those two roles, but because we have done that piece of scoping work. But we will make sure that we obviously will continue to do that, because the bit about being about destabilising one organisation to support another, that's not the ethos of the way that we're trying to actually roll this out. And then when we're talking about the underspend, I'm really keen now, because there are 10 roles this year. I am really keen that we support and almost push, making sure that the clinical directors and the PCNs are involved early and in the employment and the recruitment drives that we're doing. So we work with them very closely, as you know, Jonathan, and it's that bit really. So if people want to go and do their own thing, then that's absolutely fine. But we also encourage them to be part of the county-wide campaigns, recruitment campaigns as well. So once we get to there needs to be a workforce plan that needs to be done in, forgive me, I think it's by the end of August. I think that was slightly extended because of COVID. And we need to do a workforce plan. Well, obviously these PCNs do. So by the time we get to having that workforce plan, we will then know how much the intended spend is, and therefore potentially what the potential underspend might be. And then we can have conversations about what we're going to do with that.
Okay, so any further questions? So from my point of view, obviously Julie and I had conversations about it beforehand. I think that the eminent logic of actually trying to protect as many roles as we possibly can and be adaptable is a good thing. I think it shows good co-working with the PCNs and the CCG having a flexibility to make decisions and act quickly, which I think is positive. So is everyone happy to ratify this decision? I'm getting nods and no one is recording no in the chat box, so that's fantastic, thank you. We don't have finance on the agenda, mainly because I don't think there was anything to update following the last meeting, but Andrew, do you want to confirm if that is the case?
Yes, we're still awaiting for guidance from NHS England on the new financial regime for months 5 to 12. So everything remains as Stuart reported previously, that NHS England are funding us to a break-even position for the first 4 months. So that position remains.
Fantastic. Well, we have our next meeting on the 1st of September. If anything comes through in that interim period, do feel free to circulate to the committee sort of in advance of the papers going out, because I know people won't have time to consider any implications, but thank you for the update. So I now move to request that the committee pass a resolution to move into the private sector to consider private items of business in line with the Public Bodies Admission to Meetings Act of 1960. Is everyone happy to move to the private meeting? Thank you. And Christine, if you wouldn't mind stopping the recording, that would be lovely. Thank you.